1 year later, I had lost 80 pounds. And surprisingly, my calcium score went down to 1. It is claimed in the literature that you cannot use coronary calcium score for regression purposes. You can use it for progression purposes. I did change machines. The prior two calcium scores were done on what is called an EBCT machine, which is probably a little more accurate than the newer machine that was done on a Siemens 64 slice, multi-slice CAT scan. Variation in the CAT scan is supposed to be 40%. So even using a 40% variation on the number 20, I don't think it should be as low as 1. So I think this shows that I did have regression, even though once the calcium is in the wall, it is claimed that it does not leave. This point is not very clear. At least I was very happy. In fact, I was elated with my weight loss and increased exercise that I was able to see regression, and if not regression, at least there was not progression. Someone else might say that I could get a CAT scan the next day and I'd be back up to 20. Well, I didn't want the radiation, and unfortunately the EBCT machine that I had used before had shut down because Siemens bought out all the EBCTs and wasn't making them anymore. As you can see, my LDL particle number was excellent at 623. At this time I was on Crestor, and at this time I also was able to get a CIMT of my carotids. Now this study is much better to follow Plaque because it's just ultrasound. So I won't be exposing myself to radiation any further. The CIMT was 0.743 on my left artery. This made my artery about 55 years old, which is about my age. My right artery was much younger. It was in the 35-year-old group. But you always use the artery that has the thicker plaque. A year later, I was able to get a follow-up CIMT. And amazingly, my left artery went from 0.74 to 0.58. This is a remarkable reduction in plaque thickness in someone who just gained 20 pounds of the 80 pounds that he lost and who was not statin naive. The apparent improvement may be because I am ApoE4, and people with this genetic makeup seem to respond extremely well to statins. These are the people who also do very badly if they continue to smoke. What's interesting is that it's been told to me that a plaque thickness of 0.3 millimeters is normal. And I contend that no plaque is normal if we are saying that no plaque is healthy, meaning no disease. There are databases for manual technique CIMT. For the youngest database, which is 25 years old, if your CIMT is less than 0.51, then you have a less than 25% risk of getting an event. That seems awfully high for a 25-year-old, and I am concerned of all the 20-year-old people who may have 0.3 millimeters with metabolic syndrome. Are we going to say these people are normal and not treat them? What's also interesting is that many years ago when CIMTs first came out, it was said that 0.6 millimeters was normal. Thus, as we keep lowering the LDL standard, I think the CIMT number needs to go as low as possible as well. But this is something we can follow every 2 to 5 years. In most studies, they don't find results till 2 to 5 years. Interestingly, I had results after 1 year. Again, in full disclosure, these were different machines. I don't know if the first machine was manual or semi-automated. The second machine was semi-automated, which my sonographer tells me he thinks is slightly more accurate. You may be amazed to learn that I am only on Crestor 5 milligrams a day. This is consistent with my philosophy that only a moderate dose of statins should be used, because I am concerned that if a patient is unmonitored further down the road, and if we are going to give these drugs for a long time, that may happen. That rhabdomyolysis may happen if the person does get sick or gets on some drugs he shouldn't be that interact with it, and he does go into rhabdomyolysis. In the Jupiter study, there was a 90-year-old person who was on Crestor 20 milligrams a day, and he developed rhabdomyolysis. In fact, he was the only person out of 18,000 people who did. But he was 90 and he caught pneumonia, and he did develop it. That is why these drugs should be stopped during an acute illness. I am a strong believer in fish oil. The Loveza, a gram a day, reduces sudden death, also makes the LDL. Enduracin 500 twice a day is known to lower HDL at that dose, but recently it's also found to lower LDL by about 10%. Traditionally, it was felt that you had to get up to 2 grams of niacin to see good LDL lowering numbers. I was on Actos because of my weight and my insulin resistance. You may be interested to hear that after I lost 80 pounds, I was able to stop taking insulin. Ramipril is an ACE inhibitor. Again, this is to keep my blood pressure under systolic 120 and to prevent proteinuria as a diabetic. Glucophage, again, is for my diabetes, and aspirin is to thin my blood to prevent strokes and heart attacks. Most people probably only have to take aspirin 81 milligrams every other day, but in order to improve compliance, you should take it every day. If you are at high risk, I do recommend getting an aspirin resistance test with your urine, and if you are resistant, then go up to 325 milligrams a day. If you are still resistant at that dose, I would recommend, if you are very high risk, going on Plavix and adding on aspirin 81 milligrams once a day. Take the 2 drugs, Plavix and aspirin, together. Again, that's for the very high risk. Aspirin 81 milligrams once a day is for people over 45 or men, and for women over 55, but in particular if they have disease, as mentioned earlier.